Well, thank you so much for inviting me, Rashmi, and it's a real delight to be here today. You should all note that I'm actually an adult pulmonologist. I know nothing about children other than the 3 that I've raised. I know nothing about rheumatology, so take all of this with a grain of salt. But what I have learned over the last 15 plus years that I've been at Hopkins and working with my rheumatology colleagues in this field of autoimmune-associated interstitial lung disease is that the body is a heck of a lot smarter than we are, and many of the challenges that you're describing are challenges we face as well. And so what I'm going to really tell you about is, as a clinician, how I think about autoimmune lung disease, particularly in rheumatoid arthritis and poly and dermatomyositis. And because we've got a very kind of heterogeneous audience here, I'm going to talk a little bit about sort of very general things, and then I'm going to dive into some of the more specific things. Okay, so some of you may know that Hopkins has this odd affiliation with William Osler. He was our first professor of medicine. He did a lot of stuff I don't like, but he had some amazing quotes, and I love this one. One special advantage of the skeptical attitude of mind is that a person is never vexed to find that after all he has been in the wrong. And I think that as clinicians, we all need to be very mindful of the fact that much that we believe is actually either incorrect or will be shown to be incorrect. And therefore, everything that we say should be taken as in the process of finding out what's actually correct. So I want to frame my discussion in the clinical realm. And so in doing that, what I want to do is I want to give you sort of an overview of the clinical entities of rheumatoid arthritis and dermatomyositis. And when I use DM, I'm really talking about dermato and polymyositis, and I'll explain what the difference is. I want to talk about the nature and prevalence of lung involvement. I want to talk about risk factors for the development of interstitial lung disease. And these will fall into 2 categories. Those are demographics related to the patient and then autoantibody production. I want to talk about how ILD impacts on morbidity and mortality. And then I just very, very briefly want to talk about treatment strategies. Okay, so this is a sort of a comparative slide, largely because as a pulmonologist, I think of my patients as having ILD, and I think of them secondarily as the autoimmune disease that brings them to my attention. But let's just kind of talk about these 2 populations. So rheumatoid arthritis actually is an amazingly common disease in the aged population. It affects about 1 in every 100 people. So that means that there are about between 1.3 and 1.4 million Americans in the United States who have this disease. Like many autoimmune diseases, the ratio is towards women, so women have more disease 3 times as much as men. The average age of onset is in the later years, in the 60s. And the clinical presentation is typically a slowly progressive presentation with morning stiffness and then can affect more and more joints. You can have variable involvement of the lungs, the eyes, and the cardiovascular system. And I think one of you made the point that this really is a systemic disorder. So when we talk about these autoimmune diseases, although it may be called rheumatoid arthritis, i.e. inflammation in the joints, this is actually an autoimmune systemic disorder that also happens to be characterized by joint disease. You can have rheumatoid nodules. The risk factors that we know about are environmentally smoking is a very potent risk factor for the development of rheumatoid arthritis, as well as for the development of rheumatoid arthritis lung disease, and the genetic risk factor of HLA-DRB1. Now, when you compare this to polymyositis, dermatomyositis, this happens about 5 in 100,000. So this is an amazingly rare disease. So in the US, in total, there are about 16,000 adults who have this. In comparison, if you look at the data for CF, which many of you would be familiar with, CF affects about 30,000 in the United States. So I think of CF as being an incredibly rare disease. This is half of an incredibly rare disease. The male to female ratio is again showing predominance in females, about 2 to 1. The peak age of onset is a little bit earlier, it's in the 50s. And again, this is a systemic disorder. It affects muscles, joints, lungs, skin, heart, esophagus. And interestingly, similarly to the fact that you can get nodules in rheumatoid arthritis, you can get calcinosis, which are essentially calcium collections in patients who have PM and DM. We don't actually know what the environmental risk factors are, although they're very likely to be them, and I'm going to talk in a little bit about this issue of cold, so we'll come back to that issue. But again, there are specific HLA alleles which are associated with a higher risk of PM and DM. So you can see that there are a lot of similarities. The major difference is the frequency with which we see these diseases. Okay, so what about the lung? So rheumatoid arthritis, I told you, is an amazingly common disease. And it actually affects all portions of the lung. This should sound familiar from your discussion about the pathology in SJIA, interstitial lung disease. You can have parenchymal involvement, pleural involvement, airway involvement, vascular involvement, so really every compartment. Now, interestingly, only about 30% of patients who have RA, that's diagnosed based on the classification system that exists currently, will manifest lung disease. What I can tell you is that when they've done some biopsy studies and autopsy studies, it actually is present in about 85% of lungs at a microscopic level. So this gets back to the, do we always know we have it when there's the pathology to go along with it? PM and DM are slightly different. They're predominantly parenchymal and vascular diseases, and interestingly, we have very vasculitic components with or vasculopathy with patients who have particularly dermatomyositis. There is some airway involvement, but it's a much less common feature. On the other hand, in patients who have these diseases, up to 90% of patients have primary lung involvement. So what that means is that you have an amazingly rare disease in which you have highly penetrant lung disease. This is much like that image you saw where you can have rare mutations that have a very strong impact, or you can have common mutations that have a very weak impact. So we have these rare diseases. I won't say they're mutations, they're rare conditions, and they have an extremely high risk factor related to the formation of lung disease. Okay, so how do we decide if a patient has rheumatoid arthritis? Now, I actually find this quite amusing as a pulmonologist because pulmonologists are never as concrete as this. We're a much more go-with-the-flow kind of group. So the rheumatologists very carefully point out that this is not actually a diagnostic criteria. It's a classification criteria, and I'll let them discuss with you why there's that distinction. But basically, you go to the menu, you say, do I have enough points out of, joint distribution, serology, symptom duration, and acute phase reactants? And if I do, then you've got definite rheumatoid arthritis. And I will point out to you that this is updated in 2010, and there's no mention of lung disease in this. So this is going to be a common theme, is that even though the lung is very frequently, a third of patients have symptomatic lung disease, it is not part of diagnostic criteria for rheumatoid arthritis. Okay, so what does rheumatoid arthritis look like? Well, this is a patient who has an early RA where it's still very inflammatory. They've got very swollen joints. Typically, it starts off with sort of this morning stiffness that will then go on to having multiple joints involved with more and more difficulty and disability with movement and with tenderness. Typically, affects multiple joints. It can go away spontaneously. Again, very common. Some patients get better, then they get worse again. Why does that happen? And it has a very strong systemic symptom burden. So lots of fatigue, malaise, and depression. And we say, okay, well, if you're hurting, no wonder you're tired, or no wonder you feel depressed. But I think that this also speaks to the fact that there are probably more profound systemic impacts of these circulating cytokines potentially that lead to a lot of these other symptoms. Now, this is what happens if you don't treat it early enough. And essentially what happens is that you have destruction of the joint space with essentially like a reconstruction of it in a fashion where the joint becomes deformed and fused. And in general, we're seeing this less and less because rheumatologists are really smart. And they've managed to think of all of these wonderful drugs that actually fix this problem. So while I have a group of patients who have some of that, most of these patients are in their 80s or 90s. Most of my younger patients with RA, their hands look as good or better than mine do. And that's because they were picked up very early. They were put on disease-modifying therapy, and they'll never develop this kind of disease. Now, There was a lovely review recently in the European Respiratory Journal, and what it points out is now let's switch our focus to the lung. So the lung truly can be the site of many different forms of injury in rheumatoid arthritis. So the thing that I spend most of my time thinking about is the interstitial lung disease, and what you'll see is there's descriptions of the patterns. You've heard about that a little bit in the talks, in the pathology talks. I'll point out that usual interstitial pneumonia, which somebody mentioned is similar to this disease, can be present in this disease, idiopathic pulmonary fibrosis, can also occur in rheumatoid arthritis. This is a pattern, that's a pattern recognition. It has nothing to do with the disease. I always tell my trainees that interstitial lung disease is a symptom, it's not a diagnosis. So you have to actually get to the thing that caused that symptom in order to figure out what you need to do. So this presents in a variety of ways in parenchymal lung disease. You can have very significant pleural involvement with pleural effusions, with trapped lung. You can get a lot of airway involvement with rheumatoid arthritis. And in fact, this is a little hard to separate because, again, as I mentioned, a very potent risk factor for rheumatoid arthritis is actually smoking. And obviously, smoking causes a lot of airway diseases as well. You can have these nodules. You can definitely have vascular disease, and you can even get vasculitis. You can get pulmonary hypertension in rheumatoid arthritis. So I think what you're hearing is that we have a huge amount of overlap in terms of the presentations. And last but not least, you can get drug toxicity. And I want to really point out the fact that this is a common theme amongst all the interstitial lung diseases, especially in autoimmunity. We always are trying to separate, is this due to the disease, due to our treatment, due to an infection that we've caused by our treatment? So those are constantly in play when we think about patients who have lung involvement. Okay, now this is one of the schematics, and I have two thoughts about it. The first thought is that I was always told you only made a schematic when you really didn't know what was going on. And the second is that this really speaks to the fact that people have spent an enormous amount of time and energy thinking about what causes RA and characterizing the biological changes that occur with it. And I want to just highlight this. I've talked about most of these issues already, but I want to highlight this, and then I want to show you the next slide. So we know a whole lot about the systems. We have a lot of great drugs. We can treat patients who have rheumatoid arthritis. They don't develop deforming arthritis anymore. I will tell you that over the period between 1988 and 2004, the overall mortality rate for patients with rheumatoid arthritis either stayed the same or decreased, okay? So over this period of time, patients who had rheumatoid arthritis lived longer and had less disability. But when you then break out the mortality associated with interstitial lung disease, you can see that that has been steadily stepping up in terms of the cause of death in our patients with RA. So despite the fact that we are super smart, know what causes this disease, can keep your joints working well, better and better at dealing with the cardiovascular side effects of RA, our patients are dying of interstitial lung disease. This is the final frontier. It's the part of autoimmune diseases that is actually killing our patients, and I think that that's very much why there's so much focus and concern about it here. Okay, I'm going to change gears. I want to talk about myositis. I told you myositis is incredibly rare unless you're in my clinic. If you're in my clinic yesterday, there were 12 of you who had myositis-associated ILD in my half-day clinic. And so what we've done at Hopkins is we've developed a multidisciplinary diagnostic group for myositis spectrum disorders. We have rheumatologists, pulmonologists, neurologists, physiatrists. So we have a really big group, and it's been one of these, if you build it, they will come kind of situations. So at this point in time, I literally cannot see all the patients who have come to us with this fleetingly rare disease where there should only be 16,000 in the country, and we've already seen 5,000 at Hopkins, and I know we have not seen 1/3 of all of the patients in the US. Okay, so this was the diagnostic criteria. I think one of you said you're from Sweden. I was actually just there. I was just visiting Ingrid Lundberg. Are you at Karolinska also? She is. She's wonderful, and she has really pushed this field forward. And much of the knowledge in this area is completely due to the work that she and others around her have been focusing on. So. She recently was involved with the development of new criteria for inflammatory idiopathic myositis. And this was an update essentially based on Bohan and Peters' criteria from 1975. And so you can see that the criteria are also very similar to rheumatoid arthritis in the sense that you've kind of got a menu. You have some clinical criteria that you should have. You should be over 18, subacute onset, you should have symmetric weakness, you can have a rash, you should have an elevated CK, you should have other abnormalities, including maybe a myositis-specific antibody, and then there are the muscle biopsy inclusion criteria. And once again, 90% of patients who have certain forms of myositis get interstitial lung disease. Nowhere on here is lung disease even considered this. Why am I making this point? Because for the longest time, we did not actually recognize myositis patients who presented with what is lung disease. And I actually asked the question to several of you, is it possible that sitting in your pediatric pulmonologist's office is another group of patients who actually are part of this group that you're seeing, but they just don't have some of these systemic manifestations? So I think that from our experience, this is something that you all really need to think about. Maybe you've already thought about it and know the answer, and you'll tell me afterwards. Okay, I want to start off just because we've talked about sort of systemic manifestations, I want to show you how patients present with this disease. So if you're a dermatologist, this is what you know about dermatomyositis, which is essentially polymyositis plus skin rash. And so in this situation, what you can see is a wide variety of rashes. The interesting thing is, if you look at this and you kind of squint, a lot of this looks not terribly dissimilar from some of the other things you've seen today. So you get this characteristic rash on the back of your hand, you get erosions around your fingernails, you get this thing called mechanic's hands where you get kind of a hyperkeratosis at the tips of your fingers, you can get it on your elbows, you can get this incredible red rash, swollen rash around your eyes called a heliotrope, and this is known as a V-neck rash, very clever name for that rash. Now, if you ask a rheumatologist or a neurologist, what is autoimmune myositis? This is what they're going to tell you. Well, it's this group of disorders that are defined clinically by muscle weakness and or pain in the muscle, and they're going to show you these nice pictures of normal muscle, and then they're going to show you pictures of muscles where you've got inflammatory cell infiltrates or perivascular infiltrates. And then if you ask me what is autoimmune myositis, this is what I'm going to tell you it is. It's a group of interstitial lung diseases. I don't know about all these people who have sore joints and sore muscles. We have patients who have interstitial lung disease, and that's what their disease is autoimmune myositis. So my patients typically show up as young, often women, who present with primarily lung disease, and by the way, they also happen to have, sometimes if we look really hard, have rash and have muscle involvement. But what they have is they have myositis-specific antibodies. So for us, that's really been a key defining feature, is the production of antibodies. Okay, so let's talk about these antibodies. There are two groups that we typically talk about. There are the myositis-specific antibodies, the myositis-associated antibodies. And within the myositis-specific antibodies, there are these antibodies called the anti-synthetase antibodies. I'm going to spend a couple minutes more on those in just a minute. But let me just point out a couple of things. So when we started in the Myositis Center, really the only anti-synthetase antibody we could commercially test for was Jo-1, and therefore everybody either had Jo-1 or didn't have an antibody. And now we can test for all of these antibodies, and surprisingly, all of a sudden we have lots of patients who have PL7 and PL12. So the point of this is, if you can't test for it, you don't know the patient has it. And I think that that's often a problem in rare diseases, where you might well find this biomarker or this signal that you need to be able to define it, but until you find it, you're never going to know you don't know it. The other thing is that we have these myositis-associated antibodies, and these are essentially patients where we have kind of not really figured out what we want to call them. Rho52, you might recognize, it's associated also with Sjogren's, but we find that Rho52 is actually very commonly a marker for our myositis patients with interstitial lung disease. PMSCL is one for an overlap between scleroderma, which is a vasculopathy, and polymyositis, which is presumably not a vasculopathy, but maybe is. Okay. All right, so let's talk about anti-synthetase syndrome, because I think that this is part of the mystery of autoimmunity and maybe the mystery of autoinflammatory diseases as well. So anti-synthetase syndrome is actually defined by autoantibodies against this thing called aminoacyl tRNA synthetases. And you'll remember from medical school or biology or biochemistry that when you go from RNA to protein, something has to sit down on the RNA and say, okay, I recognize this and I'm going to attach this amino acid. And that's what aminoacyl tRNA synthetases are. So firstly, there are 20 because you have 20 amino acids in any tissue, and they're in every single cell in every part of your body. Now, to me, the fact that this can be a target for autoimmunity is one of the most fascinating things. It's why I actually go to work every day, because someday I will be ready to retire when we figure out why this has happened. So this is what happens when you develop anti-synthetase antibodies. You get interstitial lung disease, you get Raynaud's, you get this very intense cold sensitivity, you get variable degrees of inflammatory myositis, you can have high fevers, you can have non-erosive arthritis, and you can get this very bizarre pattern again, this hyperkeratosis on the fingertips. And so why would antibodies to something that's present in every single tissue in your body have this very, very stereotypical pattern? I don't know. I hope somebody will, maybe one of you guys will figure this out. I don't know the answer. But I think it is also a good reminder that this is not myositis. This is a disease that is a systemic disorder in which the muscle is one of the targets. Okay, and so people have been slowly drinking the Kool-Aid and starting to believe my thinking. And so this is, I'm going to show you a series of studies that have been done in different groups looking at what makes you think a patient will have interstitial lung disease. So the things that make you think that they have interstitial lung disease is that they have interstitial lung disease, that they present with this Hammond-Rich or this very acute interstitial pneumonia. Actually, the vast majority develop this progressive symptoms where, much like your patients, where they slowly evolve with their cough and then their shortness of breath. And some of the patients are completely asymptomatic, okay, even if they have interstitial lung disease. One of the other things is that this can appear at the same time, before or after any other symptoms. And so what we've actually done is looked at patients over a 2-year period when they presented with lung disease as their first sign or symptom. And what we found is that over 2 years, the majority of patients who presented only with interstitial lung disease will eventually develop some other feature of this disorder. Okay, so what happens to the patients? Well, for the most part, we actually can make most of our patients get better. About, 60, 70% of them get better, 75% of them get better. Some of them don't. We don't understand why it is that some do get better and some don't. And I think what I'm kind of pointing out is that we have a lot of the same questions that you have about your disease. All right, so this is a nice study by Josh Solomon, who's a colleague of mine at Denver. And what he did is he basically just went through the world's literature and he said, okay, let me look at these antibodies, these anti-synthetase antibodies, and let me see how often the lung is involved. And what you'll see, it's variable from, maybe 50, 60% to essentially 100% of patients who have lung involvement. And then if you look at muscle involvement, what you'll see is that Jo1, which is the prototypical anti-synthetase, in other words, the one that we tested for first, has much more muscle involvement in comparison to lung, where some of the other ones that we've learned about later have much more lung involvement in comparison to muscle. But that within each of these antibodies, you really get some variation. So if you have PL12 or PL7, you're more likely to have lung disease. And if you're an African-American woman who walks into my clinic who's 50, who's got new onset interstitial lung disease and not much else, I am practically sure you're going to have one of those two antibodies, just because we've now seen them enough to know that that's how they present. Okay, this is another, This is another interesting feature, and I'm going to talk a little bit about this antibody a bit more. MDA5, melanoma differentiation-associated genes, including RNA helicase. Now, if you were looking carefully at the talk before mine, you saw that in one of the diagrams, because this is also a sensor, is a very, very important biological sensor for RNA viruses. And what you'll see is in Asia, and I'm sorry, I don't think I have a pointer on this. So in Asia, 90% of the patients who are reported with MDA5 have interstitial lung disease, whereas in Europe and actually in the US, it's a much lower percentage. So you were talking about, is this an American disease? Well, I would say we see a different MDA5 than our colleagues in Japan and apparently than the pediatric population at the NIH. So there are things which modify these antibodies, which we can measure, that cause very substantial differences in presentation. Okay, so how do we know that a patient is going to have interstitial lung disease? Well, they might have high inflammatory markers. They might have particular antibodies that make it more likely that they'll have it. They may have other features like rash or fevers that make you more likely. But these are constellations. These are syndromic. And so we still don't know if you walk in the door today and you have Joe 1, I can't tell you whether you're going to end up with interstitial lung disease or not until you have interstitial lung disease, and then I'm sure you're going to have it. But that's not the most effective way. And similarly, when your patients present with SJIA, when they walk in the door, you don't have a mechanism yet to say you are going to be this kid who's going to have repeated episodes of MAS. You're going to be the kid who has interstitial lung disease. All right, and so you can go through all sorts of machinations, but the thing that I find interesting in this, and again, I'll just go back to this idea, is that one of the strongest factors that predicts the presence of interstitial lung disease in patients who have myositis is the fact that they don't have muscle involvement. It's that they're amyopathic. So again, it's really easy to focus on the things that you knew you should be looking for, so the patient who has the rash, the patient who has the swollen joints and things like that, but you may be turning away from the patient who actually has what is going to be the lethal disease, which is the lung involvement. All right, now this also should look a little bit familiar. This is a lady who I saw actually a couple years ago who presented with rash on her hands and face and upper chest. And then she developed rapidly progressive interstitial lung disease. And just curious, out of the rheumatologists who are here, does everybody recognize what this is? I mean, I know you'd recognize the big category, but do you know what antibody it is? So we see this in adult population, and when we see a patient who has this, we now know, I don't even have to send blood, I actually know what the patient has. This is MDA5, anti-MDA5. And so it has such a classic pattern with these erosive Gauthran's lesions that literally if I have the patient do this, I can tell them what they have. And the other interesting thing, which I'm not sure if you can see terribly well because of where the screen is, but they get the same erosive lesions on their ears. And we've found this to be to present in winter months. So they get their rash on their hands, they get these erosive lesions, and they get them on their fingers, they'll get them in their toes, and they'll get them on their ears. So very interesting. We've always thought it's related to cold exposure, but we don't actually understand exactly why. All right, so the reason we knew about this is because David Fiorentino, who is actually a dermatologist out in your neck of the woods, had really seen these patients who had this weird variant of dermatomyositis with these incredible erosive lesions. And he worked together with Livia Casciola-Rosen, who's from Hopkins, to show that these patients had this antibody to MDA5. So MDA5 had actually been reported in a cohort of patients from Japan who had this very rapidly progressive, typically fatal form of interstitial lung disease. So we thought the impression in the community was MDA5 is like a death sentence. You have MDA5, you're going to just, bad news for you. But, we looked at our patients and we said, gee, that doesn't really feel like our patients at all. So what we did is we went back and we checked for MDA5 in all of our dermatomyositis patients who did not have an antibody recognized already. So they didn't have one of those PL12, PL7, Joe, things like that. We went back and checked all of them. And we actually found that we had a large group of patients who had MDA5 who had none of the symptoms that we typically associate with it. And perhaps most importantly, these were not the patients who were dying rapidly in our ICU. These were our clinic patients who were getting better. These were people who we were treating with steroids, steroid-sparing agents, and they were either recovering to normal or they were staying pretty functional. So why am I saying this? Because we are talking about the same antibody. We're talking about on two entirely different genetic backgrounds, and we're pretty sure that the difference is actually genetic background. It could be an environmental issue. Perhaps there are viruses that are circulating in Japan, but as somebody pointed out, it seems a little bit hard to believe that you wouldn't actually have some admixture of viruses with the amount of movement and travel that people do. Okay, so you saw this in the corner of the slide that you saw in the previous talk. So MDA5 is a double-stranded RNA sensor. It is a very incredibly primitive innate immune responder, and so it is really well conserved across species, which is very helpful. So you can knock it out in other organisms, and you can get some really nice data. It turns out that it is responsible for handling rhinoviruses and enteroviruses. And I'm sorry if I've been disrupting people because I've been coughing because it's rhinovirus season right now and my patients are already coming in with it, so I've gotten an early case of it. It's coded for by this gene IFIH1. And when you knock that gene out, mice will develop a phenotype, a phenotype that looks a lot like lupus. So they'll develop a spontaneous autoimmunity phenotype. So interesting. Okay, why do we care about interstitial lung disease? Well, this is a study we did at Hopkins. These are patients who have myositis in the green line who do not have interstitial lung disease, and these are patients in the blue dotted line who do have interstitial lung disease. And in essence, your likelihood of dying is doubled if you have interstitial lung disease. Okay, so that's not really a particularly good thing to tell your patients, but it's sort of the reality of what we're seeing. And this is just to show you that in Asia, this is a survival curve, not a mortality curve. So similarly, patients who have interstitial lung disease have a much lower survival than those who do not. And this is even more so if you have specific antibodies, again, Asian population, and if you look at specific antibodies, particularly anti-MDA5, if you look at people who have clinically amyopathic, that is, they don't actually have muscle involvement, they tend to have more lung involvement, they actually tend to do worse. Why do they tend to do worse? Maybe because we don't actually realize that they have autoimmune disease and we don't actually immunosuppress them fast enough, but I don't know, I don't have data to prove that. Okay. How do we treat them? There are no RCTs. The first RCT is actually just opening now. It's using abatacept specifically with the goal of looking at myositis-associated ILD. I am participating in the clinical trial. Every trial I'm going to talk about, I actually am participated in, so just by way of complete disclosure. We have lots of case series and reports. Steroids are first line. We then go to azathioprine or mycophenolate. If those don't work, we go to tacrolimus or cyclosporin. We sometimes use rituximab, which interestingly I didn't hear you guys mention very much in this. We use a lot of IVIG. There's some case reports of plasmapheresis. We don't do that quite as much where I am. And now there are 2 clinical trials looking at these antifibrotics, which came up earlier in conversation. They are in clinical trial. I would strongly urge you, if you have patients that you're interested, please refer them through a trial, because otherwise we'll have no idea whether they work. All right, how do we tell if a drug works in an interstitial lung disease clinical trial? Well, in the past, and I would say probably in the present, we're using kind of traditional measures, including PFT, 6-minute walk test, imaging. I think you're going to hear a talk about sort of advances in imaging, patient-reported outcomes. These are all very static measures, and they tend to be things that are easy for us to measure. We like to measure things that we can measure. But what we really need are biomarkers, which we still do not have. And more importantly, we need actually technology-enabled patient-centered outcomes, because, you know, if I see you in the clinic once every 3 months, I get a once every 3-month sampling on how you're actually feeling. On the other hand, if I send you home with a personal activity monitor, or if you can give me real-time PROs, I can figure out actually how you're doing every day of the week. So I think that those are some of the things we need to think about. And so with that, I'm going to stop. We are very fortunate to have a wonderful group of patients, many of whom actually support our research at Hopkins. So this is with thanks to our patients who actually keep us focused on the right questions. Thank you very much.
Thank you. This was wonderful. I have a question in regards to the anti-synthetase antibodies. I agree that understanding how they get formed against the cytoplasmic or intracellular antigen really remains a problem, although if there is, anyway. But I have a question whether they are functional or actually if they are epiphenomenon markers. And since they are targeting specific amino acids. And since elastin, which basically is fascinating because the skin has much more elastin in these areas where you see the rash, where you continuously move this. So if this is true, do these antibodies actually target specific or prevent specific amino acids to be actually displaced in these places where you actually need elastin and you actually need a certain amino acid much more than others? Has anybody looked whether this actually could be a mechanism that kind of explains this really strange distribution of lesions?
So the short answer is no. The long answer is that there's some sense that it's actually probably not the intact tRNA synthetase that it's recognizing, but a cleavage product. And that the thing which is critical is the cleavage. And what I can tell you is that there are way more questions than we have answers. But I think you're absolutely right. I mean, the other place we see it is at the elbows, where you tend to bang your elbows. And we see calcinosis, which is yet another manifestation, wherever there's trauma points. So you're absolutely right, and I would absolutely agree that that seems like a very logical thing, but we don't have the data for it yet. Yes, sir.
I would like to ask you a question about screening, because
Yes.
you said that rheumatoid ILD increases your risk for death, but you also said that only 30% of patients have clinical symptoms versus 85% have pathologic symptoms.
Right.
And so if you set your screening bar too low, you're going to be picking up patients who may or may not have clinical disease and therefore may or may not have risk, yet you're then going to subject them to more treatments or invasive testing with or without clinical benefit. And as this disease is starting to scare more and more people, we're starting to screen more and more people. And what I tell my rheumatologist is every patient you've sent me, I found it in. But that may be because I'm becoming hypersensitive to it, and maybe that little chest CT thing that I'm seeing isn't clinically significant or not.
Yeah, so I actually think, I think a couple things about rheumatoid arthritis. One is that it's one of the few diseases that is at high enough prevalence that we can do real, like, cardiology type research on, where you have 600,000 patients. I just came from a rheumatology meeting, and we have like you all, we have like 40 patients in our series, and they have 600,000 in their clinical trial series. So in a sense, it provides an incredible opportunity. The reality is, I think it's an amazing disease because it is protective. So you have 85% of patients where if I went in and took a section from your lung, I could find interstitial disease, but only a fraction of those progress. And so that is a big issue, is how do you decide? And so one of the big questions now is, do you screen people with imaging? Do you screen them with pulmonary function testing? We don't know the answer, but hopefully in another 5 or 10 years, we'll have the answer. I completely agree with you, and we don't have the answer. Yes.
I just want to say that in the Swedish registry, we have something called the patient portal. So the patient can register from the iPhone or laptop, and that gets sent to the registry. And then we can merge that information to our journals, the electronic journals. And it's very, very helpful, just like you said.
Yeah, Ingrid actually showed me some of that, which is amazing. And, again, I mean, this is sort of, we're way behind in terms of actually getting patient voice in real time in the way we assess it. So I think that these kind of technologies, we're just lagging. Hopefully we'll catch up in the next 10 years to allow those things to happen. Okay.
So this may be completely stupid, but in the rubric of what lessons can we learn about other diseases with ILD for what we're here for, which is the MAS ILD phenotype, I started thinking about LCH ILD, which I think sort of histologically is probably different, but I don't know if anyone in the room or if you can comment on Langerhans cell. Yeah,
histiocytosis.
Because that's another histiocytosis, sort of maybe like macrophage activation syndrome, and so are there?
Yeah.
It's a different disease, right?
Yeah.
But I go to the Histiocyte Society meeting where we talk about HLH and LCH, right? So is there a lesson there? Is there something that we can learn from that patient population?
I mean, again, it's this interaction between, a vulnerable genetic individual with an environmental trigger, and I mean, maybe the thing that's lost. Oh well, for us, we see people who smoke who get it, right? And so, but the one thing I wanted to say is, y'all were talking about the differentiation, and I agree, there's a difference between the parenchymal compartment and the vascular compartment, but the lung is actually incredibly simple-minded. There are only a very few ways of injuring the lung, so many different injuries come down and end up in the same pathway. And so the thing that's weird about LCH is that you get this cystic formation. You get essentially an LIP, and then you get cyst formation afterwards. There are not very many other models. You get that a little bit in rheumatoid arthritis, common variable immunodeficiency, and Sjogren's. Those are about the only other things where you get that same pattern. So I don't know that it actually has a lot of overlap with what you're talking about today, but it's an interesting disease. Yes, please.
Last question. Thank you, gentlemen. There you go. Thank you very much. I really enjoyed that. Two probably very quick questions. One, when you see these patients, are you seeing them with the ILD prior to any treatment? And I think you are.
Yeah, very often.
Very often it's before,
Yep.
it's pre-treatment. Okay.
Correct.
And then when you look at the anti-synthetase antibodies, you had a slide that very nicely separated amino acid by amino acid. Does that mean that there's really no overlap, that they're amino acid specific, and it's not a multiplicity of
Yes.
anti-synthetase antibodies?
Yes, it actually turns out it's fleetingly rare to see multiple antibodies against multiple anti-synthetases. And I didn't really talk about this. It turns out the tRNA synthetases are very primitive, and they are probably multiple units that have actually different functions. So it may be a more complicated story than simply it's there to stick the amino acid on. But yes, these are very highly regulated. So you will see an antibody to tyrosine, but you won't see it to another amino acid, to alanine.
So it's not a common epitope
No,
on those,
no.
and then at the specific test
No.
would assign it. It seems
No.
to really be amino acid specific.
Absolutely, yeah.
But you do see lupus autoantibodies sometimes that are promiscuous, but the
Yeah.
muscle-specific ones are not.
Right, and so the interesting thing is we'll often see very high titer ANAs or not, and we'll see high titer rheumatoid factor or not. And interestingly, we're even starting to see CCPs in these patients, which I would have said probably didn't make sense. But again, we also see, we see Rho 52. And so we essentially see overlap syndromes. And so maybe the body is not as well segmented as rheumatologists would have liked it to be.
Do they vary over time, or are they pretty constant?
Oh, no. Oh, and I'm sorry, I meant to say that. We have patients where they present with completely lung-dominant disease. We get their lung under control, and all of a sudden they develop this non-erosive arthritis. So they vary over time, very
I meant the
dramatically.
antibody profiles. Do the antibody profiles, do they stay constant?
or
do they change, both in titer and specificity over time?
Titer can change. Specificity is a very interesting question. We've now done this long enough. We've seen at least 2 or 3 patients who have developed second autoimmune diseases. We just had a patient who's Joe 1, we followed for 10 years, who just presented with lupus vasculitis with high titer double-stranded DNA and necrosing 2 fingers. So these patients do change over time. We just haven't watched them long enough to know exactly how. Thank you.